Hi, Allie. I see you joined.
Hi, super excited for this.
Good, good. Allie, Christy, Allie.
Nice to meet you,
Hi,
Christy.
very nice to meet you as well. Thank you so much for having me. I'm excited to be here.
I think you and I would get along just great with all
Oh,
of your
yeah, me too, from
background.
what I've heard.
Yeah. I'm just looking at the list of participants. Um, Kind of going up. So I'm just going to give it another minute. But while people are getting checked in, I want to say good evening and thank you all for joining us tonight. For those of you who have been on our roundtable calls before, you know that my name is Kristen Alex and I'm the current Society for Vascular Nursing president. And it has been my privilege and my passion to get free education out to vascular nurses and vascular advanced practices once a month. And I am so excited, and I want to thank you for joining us for another exciting roundtable. Tonight, we thought it would be fun to combine like a crossover event, a cardiac, since it is Women's National Heart Month, with one of my very favorite advanced practice providers at University of Colorado, Christy Gamma, who is a adult nurse practitioner and assistant professor in the Division of Cardiology at the University of Colorado. And she currently serves as a lead APP for the general cardiology team. She's originally from Louisiana. She attended LSU and she received her bachelor's degree in nursing. She, like me, got her master's in science and nursing from University of Colorado Health Sciences in 2012 and began her career at the VA here and joined the University of Colorado in 2015. She's very involved in project development, including quality improvement initiatives for division, conference planning, advocacy work at the state level through her work as the Colorado chapter representative for the American College of Cardiology. And she's been recognized for many of her contributions by recently being honored with the UCH Medical Clinician of the Year and the Faculty Innovator Award for Clinical Care. And she's the co-chair for the Office of Advanced Practice Council at University of Colorado. And I had the opportunity to see Christy speak and give a talk like this just recently. And sadly, she ran out of time before she can give all the information. And I thought it would be great to have her come to one of our roundtables. So let me welcome Christy with her presentation of cardiac risk stratification for the non-cardiac surgeries. And during her talk, you're going to be able to be invited to do a poll. She's going to do some overview, and then we're going to do case discussions. So we've also invited one of our SVN board members, Allie Baird. Everybody should know Allie. She used to work at Vanderbilt in the vascular medicine department. She and Christy have a lot of crossover, I want to say. And now she's working at Healthcare of America as an executive cardiac and vascular provider. So executive health. So doing stuff on a higher level. So I want to welcome Allie as one of our roundtable panelists. So without further ado, I am going to turn it over to Christy Gamma. And I hope you enjoyed tonight's presentation. Please feel free to chime in, raise a hand, and I will be able to see your questions and ask, but it's a very informal discussion tonight. Sometimes we can take you off mute if you want to ask a direct question. So just let us know. We'll be watching. Go ahead, Christy.
Thank you so much, Kristen. Thank you guys so much for having me. I'm really excited to be here to discuss this topic with you and just generally be here and be involved. So thanks again for having me. I'm going to go ahead and share my screen. Maybe. Hold on one second. Let me see if this is going to work. Okay, now I'm going to share my screen. Okay. So can everybody see this okay? You can give me like
Yep.
Awesome. Okay, awesome. So as they said, I'm Christy. I am a nurse practitioner at University of Colorado Hospital. I specifically work actually in our structural heart and interventional heart program for cardiology at university, but I'm going to talk to you today about cardiac evaluation for the non-cardiac surgery. Riveting title, I know. I don't have any disclosures. Sadly, no one wants to pay me any money. So we have a few objectives. We're going to talk about how to risk stratify patients undergoing non-cardiac surgery. We're going to recognize when further cardiac testing might be beneficial. We're going to identify strategies to best optimize patients prior to surgery. All right, so I have just a little rant. Many times we get referrals that say, can you please clear our patient for surgery? So, you know, in cardiology, we don't have any like superpowers. I don't have the force. So I can't clear anybody by just like touching them and knowing what's going to happen. So what we're really doing is we're going to provide a risk stratification. We're going to give you that risk score and figure out what we can do to optimize the patient to make sure they don't have any major coronary events related to surgery. So we're not clearing the patients. And we don't put that in documentation. I just want to put that little rant out there in case anyone cares. All right, I have a little bit of nerd alert here. So because this is interactive, I just want to ask the question, first of all, does anybody know who this guy is? Am I like, I'm probably old. All right, oh wait, I see something in the chat. Yes, Urkel. Okay,
Lots
bonus
of people know
points.
it's Urkel.
Good. Okay, I don't feel so old. Bonus points if anybody can tell me like his catchphrase. And like if you want to say it.
Did I do that?
Oh, that was really good. That was really good. Did I do that? Look, I love it. People are getting it. Ooh, this is a good one. There's a lot of catchphrases. All right, so nerd alert, we're going to talk a little bit about some science. So why do we even care about what happens when a person has a surgery? So there's a unique set of circumstances that happens to the heart when a patient undergoes surgery. So you get this elevated sympathetic tone and release of all these different catecholamines. And so what that does is it increases the heart rate. It can make arrhythmias become unstable. It increases blood pressure so they can have a very dramatic hypertensive response. All of that then can lead to this increased myocardial oxygen demand and possibly the rupture of unstable plaque, which then can cause vascular injury. All of this can lead to a heart attack. And the little medications in red, we'll talk about a little bit later, but that's why it's important that we really try to look at a patient before they undergo surgery to really try to minimize that risk of having a heart attack with these special sets of hemodynamic response that can happen. Okay, so, just a little bit of data here. So 27 million patients undergo non-cardiac surgery in a year, roughly. So 50,000 of these patients are going to suffer a post-operative MI. These complications make up about half mortality rates that are associated with surgery. So when we're looking at this, we really want to look at the risk. Why is this happening? What type of comorbid conditions influence this? The complexity of the surgical procedure also can influence this risk. And the urgency of surgery is also a huge piece of this that we're going to talk about. Our goal as clinicians is really to try to reduce that risk of myocardial adverse events. So major adverse cardiac events, actually, that's what MACE stands for. So we're going to try to do our best to look at that risk, reduce it, and maybe determine the need for further optimization of, say, medicines, maybe involve diagnostic testing. So this is kind of a snapshot about when you go to review a patient to kind of look at their risks. The big picture is just all right here. So what I like to do is, if possible, I take the surgery piece out of the equation as often as I can and really look at the patient and their individualized risks. Now, if the patient's undergoing emergent surgery, if they're coming in and it's like right now this needed, I mean, there's really not a lot of optimization risk evaluation you can really do. This patient needs to go to the surgery. It needs to happen right now. Just say your prayers, hope for the best. But, if it's an urgent surgery or an elective surgery, you have a little bit more time to look at things. So you're going to look at their risks, talking about these comorbid conditions I'll expand upon a little bit here. There's some different tools we'll talk about, calculators that you can use to help really put this risk on paper. It's very important that when you're looking at this patient, you're trying to understand what type of physical activity they can do, their functional status, because that's very important with all things cardiac, but especially undergoing evaluation for surgery. And then once you get these kind of things evaluated in your mind, then you can say, okay, if this patient is having some symptoms, what do I do now? What type of testing is really going to be needed? Would I be doing this regardless of the surgery? If I do this, will it change management, or will it potentially cause harm if we delay the surgery? So, talking about these specific things. So, we're going to look at risk factors and comorbid conditions that really influence the major complications related to surgery. So, specifically coronary disease, any person that has a history of coronary disease, especially a heart attack within the last 6 months, is at a higher risk. If they've had a history of stroke, if they've had any type of heart failure, history or acute symptoms, if they have significant valve disease, meaning more like moderate to severe stenosis or regurgitation, if they have arrhythmias, specifically high-grade heart block or unstable, say AFib or ventricular arrhythmias. Age, that's a risk factor we can't really adjust, but the older you are, unfortunately, there are more complications that can be related to surgeries. You want to look at their frailty. How, there's a lot of different ways you can measure that. We usually do hand grips. We do a CAT score of their everyday living. And again, functional status, how much activity they're doing in a daily, day-to-day basis. That's going to be really important for us to try to navigate. On what's not listed on here is significant pulmonary disease and chronic kidney disease as well. So functional status, a lot of different data, a lot of different research has really looked hard into a person's functional status. So the more active you are, this is not a surprise to anybody, the better you're going to do with surgery, but the better you're also going to do for your general health, and it's actually related to longevity. So the goal is to see if your patient can achieve 4 METs. So that equivalent there is usually use an example of heavy housework. So, lifting, doing different things with housework, not just necessarily like washing one dish. We're talking about, rigorous housework, walking up a flight of stairs, walking 4 miles per hour. If you have a patient where you're not really sure what they can do and you maybe need some help in quantifying that data, you can use the Duke Status Activity Index, this calculator here on the right. And this can be found on apps as well, QX Calculate, and I believe MD Calc has this DAISY score. And then this will help kind of get you an idea about what activity level your patient's really doing on a day-to-day basis. So this is a really busy slide, but the top part of this slide and the bottom part of this slide are different guidelines, and they're both talking about surgery risk classification. So as I said before, different surgery procedures carry a risk on their own, regardless of the person's individual comorbid conditions. So surgeries are categorized in low risk, intermediate risk, and high risk. Now, most every person undergoing a vascular surgery is likely going to be considered high risk unless it's a percutaneous type of intervention, or some carotid interventions are considered intermediate risk. But aorta, most vascular surgical interventions are that high risk, meaning they carry over 5% risk of a MACE event. So again, the bottom part of the slide for your reference is from the American Heart Association guidelines, and the top is from an updated European Society guidelines. So some different tools, there's a lot of different tools that have been developed, and there are a few that have been validated, and the ACC recommends, and that's the American College of Cardiology, recommends using a couple. And I personally like this one. It's called the Revised Cardiac Risk Index. And what it does is it takes these variables of the surgery type, the comorbid conditions, including ischemic heart disease, heart failure, stroke risk or stroke history, diabetes with insulin dependency, and CKD. And it basically calculates for you what risk they would have for non-cardiac surgery. So it categorizes into low, intermediate, or high, and it gives you that number. And it's really quick and easy to use. So it's something that is just, easy to use for documentation purposes, and it's been validated, and it's one of the top ones that cardiology uses. Another more in-depth tool calculator you can use for risk prediction is the National Surgical Quality Improvement Program calculator. Now, this one's a bit more in-depth. It includes a lot of different patient factors that go into this. And the only thing that's kind of annoying for some people is you need to actually know the CPT code of the surgery that is being performed, which, whatever, you can look it up. But so it gives you a lot of different data points and it gives you a risk. So, which one should you use? You got 5 cardiology providers. Probably all 5 are going to give you a different answer on what they really like. I personally like the RCRI, the Revised Cardiac Risk Index. It's quick and easy, and it's just less data you got to compute. But I think if you want a more detailed recommendation, which is procedure specific, you can use that NSQIP. Some people use both just to get some data points in there. So I'm not going to spend a lot of time because it's like a bunch of words on the slide, but really the European guidelines, what I wanted to hit home was they've updated their guidelines in the last a couple of years, and it really focuses on age and risk factors. So it talks about what you should do based on these 2 things. So if you have a patient that's less than 65 years of age and no known cardiovascular risk factors, and they're needing a surgery, it's not necessarily recommended standard that you do a bunch of testing. If it's a high-risk surgery and they're over 45, it's reasonable to get an EKG. And, this kind of goes into the same thought process as what the ACC guidelines still say, but it maybe just focuses more on categorizing it to age and risk. What I do want to point out here is that they do specifically talk about biomarkers. That is a tool that you can use for help with risk stratification as well. And that's specifically talking about a BNP, possibly a troponin, but I personally don't usually order a troponin in outpatient unless, it's really make or break on me admitting a patient for, angina. So that's kind of a different circumstance. So just something that you can kind of keep in mind if you want to reference. So I have a couple of cases, and we'll go through the case and then we'll pull up the polling question. So case number 1, so we have a 66-year-old female with no known history of coronary disease. She's needing a knee surgery. So if we go back and look at the risk scores of just surgery in itself, knee surgery can actually be classified in the low risk, especially if it's an outpatient type of procedure. Sometimes if it's a more in-depth procedure, that's a more of an intermediate risk type of surgery. She says she's active at work. She walks several flights of stairs. She has some knee pain, but really doesn't have any other exertional type of symptoms like chest pain or shortness of breath. So her primary care, though, goes ahead, orders the ECG for screening, and it looks like the last 3 EKGs, ECG, which looks like this. Oops, maybe answer here. There we go. So I'll give everybody a chance to look at this. So, what we're seeing here is possibly some Q waves in 3 and AVF with a bigger R in V2. Could that be specific for an ischemic change? Possibly. You might think of an inferior MI that's old. Probably not, because it looked like the last 3 ECGs, but sometimes it's just the ECG mind has it's a robot that has a mind of its own. So, but it's not a rock solid normal ECG, but like I said, reassuring fact is that it looks like the last of her 3 ECGs and she's really not having any symptoms. So what do you do? And we're going to go ahead and put the polling question in now. So do you A, call off the surgery until stress testing is obtained? Do you delay the surgery and order a cardiac CT? Do you calculate a ASCVD, atherosclerotic cardiovascular disease risk score, and then use that revised cardiac risk index tool, then proceed with surgery? Or are you kind of like, just walk it off? You know what? Your knee's going to be fine.
If she can walk.
Right. Depends on how nice you're feeling that day. Y'all are awesome. Yeah, exactly. So it's for her, she's not having any symptoms. And I think it's very appropriate to just, calculate that risk score and go from there. So just kind of a note to the guidelines here. about EKGs. So do you really need an EKG on every single person? Probably not. Now, many people feel that it is a useful tool, especially in guiding some decision, but it's reasonable for patients with known coronary disease or arrhythmias, PAD, some sort of cardiac risk factor undergoing, a surgery, but it's not necessarily routinely needed in a patient that's, asymptomatic undergoing a low risk surgery. So maybe it doesn't necessarily change anything for you. But for this patient, as you said, she's got a low risk, maybe intermediate risk, depending on how they're doing the knee surgery. She's got no known coronary disease. We plug her little numbers in. She can walk more than 4 mets. So it's going to be a low risk on your cardiac risk index score. And, calculating an ASCVD risk would just be helpful because taking surgery out of the picture, you want to make sure she's optimized in life and not having a heart attack. So you might think about if she has a risk of more than 5% with her ASCVD, you could think about adding a statin. All righty. So our next case is a 75-year-old male with a history of hyperlipidemia, diabetes, and hypertension. He has some complaints of new dyspnea. But it's pretty minimal dyspnea as well, or minimal activity with that he gets short of breath. So he's like brushing his teeth and he can't breathe. Now he's needing a thoracic spine surgery next month. And he tells you, like, I don't know, I'm really not doing much activity. I'm sitting around the house. I walk like very slowly holding on to things in my home, and that's about it. So what are we going to do for this guy? We have another poll here. What do you think? Do we recommend he get an echo? What about possibly getting a nuclear stress echo or a nuclear stress test? Would you want to order a BNP or a pro-BNP to look and see if his shortness of breath is related to fluid retention? Or would you say, meh, proceed with surgery? Yeah, so I think that actually A, B, and C are all right. I would definitely order that nuclear stress test because he's got some risk factors for coronary disease, and we want to look at those coronaries. Taking surgery out of the picture, at this point, you're going to want to know what's going on with him so you can just optimize him in general. It's not unreasonable to get an echocardiogram as well, or get a BNP because that may also help influence your management there. So going back to the guidelines, so we don't know his LV function. So he's got dyspnea of unknown origin. So it's a class 2A indication. We could go ahead and get that echo and then probably go ahead and get that coronary evaluation with a nuclear stress test or a stress echo as well. All righty, so case number 3. We have a 73-year-old female. She has a history of bladder cancer, and she's already had tumor removal surgery in 2016. She has a history of coronary disease. Now, that should have actually just said PCI. Probably stent was placed in 2008 and 2009. So remote history. She's got some kidney disease. She's got lupus. She's got rheumatoid arthritis, hypertension, and some COPD. She's got like all the things. But this cancer that she has, and unfortunately has continued to grow, and she really needs this complete cystectomy. So, this is a pretty urgent surgery. Now she tells you, I'm walking daily. I don't have any pain to my chest. I don't have any shortness of breath that's different from me. I'm doing awesome. I work out doing housework. I'm in aerobics. And I mean, at this point, she's doing more than I am. So what are we going to look at? What are we going to tell her to do? Are we going to recommend a pharmacologic myocardial perfusion imaging study? So that's a stress test. Are we going to recommend a coronary angiogram? Are we going to say, we don't need to do anything, go ahead for your surgery? Or do we want to get a coronary CTA? All right, I couldn't see oh, there we go. Okay, so a couple mixed answers here. So yeah, I mean, I think that it's not necessarily wrong if you wanted to get a coronary evaluation. But we're going to kind of toss it over here to the guidelines. Now this is like probably kind of blurry, but for this specific patient, when you plug her numbers into the revised cardiac risk index, she's undergoing a high risk surgery. As we know, that's a high risk in itself, all by itself, that's associated with higher risk complications. She has this history of coronary disease, kidney disease, all the things that are going to make her a higher risk. However, this is an urgent surgery. And she's told you that she's doing all of these amazing things with her aerobic activity, and she's really not having any angina or any symptoms that are concerning to you. So could you get any type of nuclear stress testing or coronary evaluation? It wouldn't be unreasonable. But if she did undergo revascularization, at this point, she's not having an active MI, so it's not going to save her life. And if anything, it's really the percutaneous intervention would be to help with symptoms, but she's really not having any symptoms. So when you look at this risk score here on the right, what we're looking for is this emergency surgery. Now, just FYI, I'm not like a PowerPoint genius here, and I have this like tiny, skinny little arrow you probably can't really see. So I'm just going to kind of point it out here. So she's going for surgery. It's not an emergency, but it's pretty urgent. Thankfully, she's not having any symptoms or any markers of acute coronary syndrome. We look at her estimated perioperative MACE, and again, that's what we were talking about here. It's going to be high risk. But she is doing pretty well. She's doing over 4 METs of activity daily. She's got a really good functional capacity. She's either potentially going to rank in that excellent category versus the moderate category. So you could actually proceed with surgery, a 2A or a 2B recommendation without any further cardiac testing based really on how well she's doing and the need for this surgery, as you don't want to interrupt it unnecessarily. So again, that's a 2A indication for patients with elevated risk but excellent functional capacity. It's reasonable to forego further exercise testing with cardiac imaging and proceed with surgery. Again, wouldn't necessarily be wrong to get the imaging, no, but we would probably try to avoid a PCI if we could, only because then that would be dual antiplatelet therapy and potentially delay the surgery. It would be helpful if you wanted to possibly optimize medical therapy to get that, sure, but overall, it may not necessarily change your management. All right, case number 4. I just really wanted to put this case on here because I think eyeballs are so gross. I'm sorry if you love eyeballs, but this is a really gross eyeball to me. So I have a 74-year-old female. She has a history of aortic stenosis, hypertension, and she's needing pre-op assessment for cataract surgery, hence the gross eyeball picture. She's not having any chest pain. She's doing pretty good. She's not having any dyspnea with exertion. She's not having any syncope or near syncopal episodes, and she really doesn't have any heart failure symptoms. So you get an echo. This is from last year in March, and you notice that her ejection fraction is normal, between 55 and 65%. Her peak velocity is 2 meters per second. Her mean gradient of the aortic valve is 19 millimeters of mercury, and her aortic valve area is 2. So quick little review. When you're looking at a patient with aortic stenosis, we're looking for symptoms of progression of that disease, and there's an acronym called SAD. So SAD stands for syncope or near syncope. The A is angina, and the D is dyspnea, which also encompasses heart failure. So if you're looking for a person and looking at progression of the disease, you want to remember those symptoms. When we're looking at an echocardiogram, this one is following into the mild to moderate category. Severe aortic stenosis would be a peak velocity of 4 meters per second or greater, a mean gradient of 40 millimeters of mercury or greater, and an aortic valve area of 1 centimeter squared or less. So she doesn't have this, and thankfully, it sounds like she's doing pretty good, and this is a low-risk surgery. So what do we want to do? We have a poll question here for you. Do we do nothing? A, recommend surgery. Do we repeat a complete transthoracic echocardiogram? Do we refer to valve clinic for possible SAVR versus TAVR discussion? Do we recommend a dobutamine stress echocardiogram for further evaluation?
Christy, wouldn't a cataract surgery be low risk?
That is exactly right. That's what I was going to say. So she's low risk surgery because it's a cataract surgery and that's really minimal risk, less than 1% there. She's doing great. She's not having any symptoms. And we have an echo within a year. So I think that it's completely understandable that you might want to consider repeating a transthoracic echo. But it's also correct if you want to do nothing and recommend surgery. And here is why. So This is the guidelines for preoperative management from 2014 from ACC/AHA. So patients with, and this is a lot of words, so patients with moderate or greater degree of valvular disease. So she's probably a little bit more mild on those values, but if she had moderate or greater valve disease, she has an echo within 1 year without any symptoms or new clinical change, there's not necessarily a reason to do another echocardiogram. Would it be wrong? No. But if you were listening to her heart and you heard a more significant murmur that maybe you thought the progression of that valve disease has now happened, or she had symptoms, that would then, you're not wrong to get another echocardiogram. Now, if she would have had a baseline echocardiogram that showed severe aortic valve disease, stenosis or regurgitation, or maybe severe mitral valve disease, then I think you would want to go ahead and refer her into cardiology to have consultation by our multi-D team. So because she's had an echo within 1 year, everything's stable, she's clinically stable, and it's low risk, you could go ahead and tell her to proceed with surgery. Okay, so we have another case. 63-year-old male with a history of morbid obesity, had an inferior MI with a PCI to the left anterior descending artery 7 months ago. So he's needing a cholecystectomy. I really like saying the word cholecystectomy, so I'm just going to put that out there. He's having frequent pain from long-standing cholelithiasis. He's not having any angina. He's active skier, hiker, total Colorado. He's currently on aspirin 81 milligrams and ticagrelor 90 milligrams twice daily. So he's on dual antiplatelet therapy because he's had a heart attack and a stent within 7 months. The surgeon who's going to do this cholecystectomy wants to go ahead and stop the ticagrelor and aspirin prior to the surgery. So what do we think we should do? Do we say A, stop ticagrelor and advise urgent cholecystectomy? Do we go ahead and say B, performed endoscopic sphincterectomy and delay the cholecystectomy by at least a month? I wanted to put in sphincterectomy. I don't work in GI, but that sounds, maybe you would do it. Continue dual antiplatelet therapy and proceed with that cholecystectomy, or perform the cholecystectomy after holding ticagrelor for 5 days and continuing aspirin. So dual antiplatelet's always a tricky one to advise on. We get a lot of consultation for this. So low risk surgery, no current symptoms, but high risk because of the MI. Yeah, okay. So some people want to continue dual antiplatelet therapy. Some people say go ahead and get the cholecystectomy after holding TICAG for 5 days and continuing aspirin. So yeah, the answer really is going to be both C and D. So going to the guidelines here, there's a lot of words too. So this person's had a heart attack and they've now had a stent. So ideally, we want them to be on dual antiplatelet therapy for a year. Now, things arise and we need to evaluate, is it safe for him to interrupt therapy? So the next slide is going to talk about that. So kind of going down the guidelines here, it really depends on the duration and the need for surgery versus the need for thrombotic risk of that stent, right? Or the risk of thrombotic to that thrombus to that stent. So the stent has been implanted less than 4 to 6 weeks. No, we know it's 7 months, so it's not less than 4 to 6 weeks. Has it been over 30 days, but less than a year? Yeah. So we're going to go over here to the left. So is the risk of surgical delay, is that greater than the risk of thrombosis? Well, this guy's having a lot of pain. It's interfering with his life. There could be complications that arise from this. So I would say that the surgical delay is going to be the bigger risk than the risk of thrombus at this point. So if you were to say no, and you could delay that surgery, but we're going to say yes. So right now our guidelines are saying it's a 2B indication. He can proceed with surgery after 180 days. So he's out that far. But what do we want to do about discontinuing the platelets regimen? So this is from the guidelines. First of all, we've kind of already established that you can go ahead and interrupt. For any surgery, if possible, we would like to keep him on dual antiplatelet therapy. That's always the number one thing. But if the surgeon's like, I really don't want to do this on the ticagrelor, then what we would want to do is you could go ahead and discontinue that platelet receptor inhibitor, the ticagrelor, in this specific situation, but you would want to go ahead and continue the aspirin. So the aspirin we really, really want to hold on to. Now, as far as aspirin in general, there's been a lot of news about aspirin. It's, people get really nervous about taking aspirin, but he has a indication for aspirin. Coronary disease is an indication. We wouldn't necessarily prophylactically start a patient without known coronary disease or other ischemic events on aspirin, because that could increase the risk of complications. But in this case, if we cannot continue the dual antiplatelet therapy for this low risk surgery, we would then go ahead and interrupt the ticagrelor, but continue the aspirin. So do you think we need a coronary angiogram for this? No. So I know this guy had a heart attack, 7 months ago, but doing pretty well. We're not routinely doing coronary angiography because it's not really going to change our management unless he has some other indication for it, such as angina or new markers that he might be having a heart attack. So there's not really a need for a preoperative angiogram for screening. Alrighty, so another case here. We have a 62-year-old male with coronary disease. He's had a heart attack in 2022. He's got diabetes. He has a remote history of a stroke, hyperlipidemia, and hypertension. Now he needs a shoulder surgery. So depending on how they're going to do this shoulder surgery, that could be an intermediate risk or possibly a low risk procedure. He denies any type of cardiac symptoms, only the right shoulder pain from this torn rotator cuff. He's walking 3 miles a day. He's taking all of his meds. Super good patient, like amazing. And we're going to look at his med list. He's got 81 milligrams of aspirin. We're going to look at see that he's on a atorvastatin at 80, so that's a good dose. He's on lisinopril 10. And in the clinic visit today, his vital signs, his blood pressure is 140/80, and he tells you that's basically what he's running at home. His heart rate's 80, his oxygen level on room air is 99%, and you go ahead and you get an ECG and you show normal sinus rhythm, rates are in the 80s, no advanced heart block, no other rhythm disturbances. So this is kind of talking about optimization here. So what are we going to do for this guy before he goes on with his surgery? Are we going to order a stress test A? Are we going to hold all those medications the day of surgery? Or are we going to add a low-dose beta blocker and recommend continuing 81 milligrams of aspirin and then go ahead and say, go ahead, that shoulder surgery? Yeah, okay. So some people are saying order stress test. Some people are saying add that low-dose beta blocker and recommend continuing the aspirin, then go ahead and proceed. So, going back to this, low to intermediate risk surgery does have a history a couple years ago of coronary disease. So it's going to put him at a little higher risk, but he's super active, not having any symptoms at this point. So if we got a nuclear stress test, what type of management would that change? Could it potentially help us guide medication changes? Sure, it could. We might do that anyway. But in a person that's not having any angina and not having an acute coronary syndrome type of presentation with a low to intermediate risk surgery, he's probably going to be on the relative lower risk side if we plugged him in. And revascularizing him, sending him to the cath lab if you got a positive study, might not do anything for his benefit, and it may delay his surgery. Now, it's not wrong. We could definitely get a nuclear stress test to make sure everything looks stable. But I think for this patient, regardless if we go with imaging, we would want to go ahead and lower his blood pressure a little bit more and give him some added protection with that beta blocker. And the baby aspirin, we would like him to continue that. As we talked about, we want to make sure we continue people on aspirin if we can. So this is that little nerd alert slide again on my science. And what we talked about, what happens with surgery, you get that elevated sympathetic tone and that catecholamine release that can sometimes happen and increase the heart rate and increase the blood pressure. So beta blockers, metoprolol, that can really work on lowering this risk of heart problems right here. So that's one of the reasons that it's used. Statins, again, it really tries to help stabilize those plaques, has that anti-inflammatory effects. And so we would want to make sure a person's on a statin. And aspirin, as we talked about, that's going to be key to making sure that we reduce the risk of thrombotic events related to any type of surgery. So beta blockers, what do? Well, they do reduce MACE, but there's actually no data that shows that their effect on surgical, the risk of death is lowered. But if they're already on it, we would want to definitely continue, especially if they have coronary disease. And you would then consider starting if they have a significant indication, such as that coronary disease history or 3 or more risk factors that you can find in that revised cardiac risk index. So if they've had diabetes, kidney disease, hypertension, other things that you might want to have this medication on board for. If you decide to start it, you don't want to just do it the day before surgery, because beta blockers can sometimes increase your AV block. And so you want to make sure that a patient can tolerate it. Plus, they have some side effects. It can decrease blood pressure. So you want to make sure you give it a little bit of time to see how they do on a beta blocker. And statins, as we talked about, this is a class 1 indication regardless of surgery. If a patient has coronary disease or an elevated ASCVD risk score, you want to go ahead and get them on a statin. You want to continue it if they're currently taking. Don't stop it before surgery. It's reasonable definitely to start prior to a vascular surgery, because this is a high-risk surgery. And most times patients who have vascular disease have an indication for a statin anyway. And you want to consider it in patients with clinical indications undergoing any high-risk surgery. So again, looking at their overall risks for coronary disease and if they would be a good candidate for a statin. Other medications, we're not really, there's not a ton of benefit. We don't really want to just start an alpha-2 agonist. There's not, that's kind of fallen out of favor anyway. ACE inhibitors, these are a great benefit in many different areas. Diabetes, if they have risk factors, you definitely could start it. Continuing one is definitely reasonable for most surgeries. Some people will want that held just because of blood pressure changes, and that's understandable. That's a discussion for the surgeon. Calcium channel blockers, there's some possible cardioprotective effects, but there's not a clear recommendation to start a calcium channel blocker for a patient that needs a surgery unless there's another specific indication for it. So with that, I'm going to kind of wrap up in our summary here. So when you're looking at a patient for non-cardiac surgery, you want to consider the risk factors specifically of that patient. You want to look at their functional status. You want to consider that surgical type. What type of risk does the surgery by itself carry? You want to consider the cardiac testing if you feel like it's appropriate, if you feel like it's going to change your management and would be beneficial for that patient and not hinder a surgery if they really need it. And you want to consider using perioperative cardiac risk evaluating tools. So you can use that revised cardiac risk index calculator. You can use that NSQIP. Those can be found on an app called MD Calc or QX Calc. You can always refer to cardiology for a more in-depth evaluation. At university, we have e-consultation now, which has been really helpful for primary care providers, especially that may not know, what to do with a specific ECG finding, and we can help kind of navigate that. And as always, you can refer to the ACCHA guidelines and the European guidelines for more specific evaluation. Thank y'all so much for your time today and inviting me. I've really enjoyed being here. And if you have any questions, I'd be happy to take them or comments.
Go ahead, Allie.
I just wanted to say that was like so fluid, so amazing. Okay. You can tell how not only comfortable you are presenting that material, but just how many patients that you're probably seeing with complicated histories. And I'm sure a lot of our panel or people that joined tonight have a lot of questions, and probably specific questions from today, that the patients they saw. Do you get a lot of questions related to anticoagulation and when to stop and restart? Because I know that's probably pertinent to a lot of our listeners on this call.
Yes, anticoagulation is like a whole other beast, which is one of the reasons I didn't put it specifically in this presentation, because it's so patient dependent and dependent on the reason, that they're on anticoagulation. And, it really depends on the surgery. And that to me is one where I usually try to involve a multidisciplinary approach, because it's really tricky.
Yeah, for sure. I mean, you just taught me so much, but my prior uh job as a vascular medicine NP, I did a lot of anticoagulation recs because I feel like the surgeon or the surgery practice is looking towards the owner of the anticoagulant, like who prescribed it, who wants to own it, and who wants to manage it, and who feels comfortable starting and restarting or restopping, whatever. And to your point, it differs patient to patient. And, with VTE, if it's within the first 3 months, but it's a really need to have surgery, you have to kind of think about the options.
Exactly.
And
Exactly.
not to mention everybody's on like low dose Xarelto now. Like,
Exactly.
so which one do you stop? Which one do you continue? The aspirin, obviously.
Right. And if
But
they have more than one indication, we have some patients, especially that have mechanical heart valves and maybe they've had a VTE event, within a certain time period. So does that require hospitalization for like heparin bridging and things like that? So that becomes pretty complicated where we usually just have that multidisciplinary approach. And we have really great pharmacists in our anticoagulation division that really help navigate it too.
that's great. I want to give the opportunity for our people to ask some questions before I ask another one. And I think we have a lot of participants, so I'm impressed. And I know that they all loved your presentation.
Thank you.
Yeah, I could listen to this talk over and over and over again, which is one of the reasons I asked you to do it again. But
Well, thank you.
what I really loved is how you basically, there's a lot of nurses on this call, there's a lot of advanced practice that have gut feelings, right? You have these patients who come to you and their surgeons are recommending a surgery. And then all of this time, they'll call the nurses in the follow-up and they'll say, oh my God, well, what's going to happen? Like, is my heart going to be okay? Which I tell my family members, should I, do this? And this talk just walked us through so brilliantly little tools to give us kind of little feedback. And actually, like, when your gut feeling is saying, well, I don't know, well, maybe you'll be okay, maybe you'll be moderately okay, like now I have concrete from the data that you just nicely summarized to put out there. I know I was writing notes about Duke frailty and the Lee variables and making sure I have that on my empty calc, because I too just saw someone in clinic who has a 6 centimeter aneurysm, who may have to have an EVAR, who now I'm thinking like you, do they fall into the high risk category? And then what are her other comorbidities? So I'm like, do you keep these tools like somewhere in your clinic? Is there anything that's been very helpful for you, Christy, to like just as a reference to these patients?
Yeah, I usually just use my phone and then calculate the score in there, and then I have kind of a statement that I use surrounding the risk. So for example, if I'll say in there something like this patient was here for evaluation of whatever surgery, according to the revised cardiac risk index as, tool from the ACC guidelines, this patient is, 8% chance of risk for a MACE event or whatever it may be. And so, and then I'll say, discuss the risks with the patient. And we've then decided that because the patient's able to achieve so many meds, and I give the examples of what activity they're doing, and they're optimized on a statin, an aspirin, a beta blocker, whatever it may be, we feel comfortable proceeding with surgery, understanding these risks. I actually don't know if in Epic they have it in there. I haven't used like a dot phrase to see. I'm not sure if they do. I know a lot of people will just use it and then like copy and paste the actual data from like a computer into their note. But that's kind of the way that I phrase it. I just kind of have a discussion. I put in the data. But to your point, if this is just a guideline. So if your patient is, you have that gut feeling, or your patient is telling you something that may not fit in this picture perfect category, it's okay to get more data. It's okay to do a little bit more testing. It's just really trying to understand what you're looking at here and what you're going to do with that data once you get it.
Well, and I think a good point, especially of Women's Cardiac Month, is women's cardiac symptoms are often more subtle than men. And, when they call in with things, I typically like tend to overreact almost to them.
Yeah, it can be really difficult. And, I think if you talk to a lot of different people in cardiology, they may have a little bit of a difference in the way they handle things. For example, some people get really annoyed and don't want to get an EKG and that kind of thing. They don't think it's going to change any management. I don't mind an EKG because if there's something that's changed on there, especially in a female, then it may prompt me to do more testing because that, to your point, females can sometimes have different symptoms and it may change that management. It may be needed. Now, if it's a cataract surgery, probably not. But if it's like an aortic or, vascular surgery, especially, and we really want to make sure we're covering all of our bases and not missing anything for this person in general, I think it's completely reasonable to really go with your gut on that.
Perfect. I would also like to add, anytime you add a valvular word in any sort of history or any sort of like past medical history and your patient's going to surgery, usually anesthesia is like, where's the echo? Like, I always
100%. That's why I say you don't necessarily have to, but in the back, I actually just got a secure chat about that like an hour ago that anesthesia did an echo, even though this guy had one 6 months ago. And guess what? It did progress. So it can happen. So it's not wrong. It's just that you don't necessarily need it if you don't have any other reason to do it.
Yeah, I feel like you see all these patients, you order these testing and like you see normal results, but then that one patient that kind of resets your mindset because you found something and you prevented something huge, it just sets the tone and makes you even more thorough with, I'm sure, all the patients that you see.
It is true. I mean, you really, of course, like all of us, right? When we're in healthcare, we're not perfect. Especially if we think we've missed something in the past or whatever it may be, you want to just double, triple check and make sure that's not happening again. And it's like in general, even if you're undergoing a stress test, there's a risk there of having a heart attack for any single person, regardless if you have coronary disease. But I always tell people, you have a risk of getting hit by a car when you walk across the street. I can't, there's risks in life. We're just trying to do what we can to really optimize it so you're not going into something blind.
Yeah.
For
Well,
sure.
I think some really nice triage points too for patients with valvular disease, especially for our nurses in the audience tonight with the syncope, anginal symptoms, and dyspnea, the SAD. That's a great acronym that I have not heard for a while, or maybe it was suppressed. But just when you get patients on the phone, because our nurses do a lot of triage for shortness of breath. And I remember, I think I just sent somebody your way who had anginal symptoms and she had every risk factor for cardiac disease. And, the schedulers are like, oh, I'll see her in 6 months. I'm like, no, I need her to see someone in a month, like less than that. So it's really dynamic. And one thing that I'm really glad that we get to do at the Society for Vascular Nursing is record this and have it up on our website. So if patients or if people that are out there tonight want to reference something, it's all right there, because this is such a great and dynamic talk. I know it was really hard for you to put together, and it's probably not as exciting as structural heart, but it's equally important.
But it also encompasses a lot of people, right? Because I mean, a lot of people will come into contact with patients that are going to need evaluation. And it's like, as you said, from all of our specialties, our nurses, our sonographers, all of our different healthcare specialists will, come into contact with a person that's going to undergo surgery. And it's helpful to know some of the thought process behind there. And I'd be happy to come back and do a valve talk, which might have more pictures, but more gross pictures too. I'm a gross picture person, but and I have my email here too. So in case y'all have any questions and you don't want to ask tonight or you think of something later, I'm happy to always answer questions or be available for comments or anything like that.
Allie, do you have anything else?
No, I just want you to be a member of our society.
Yeah. Okay.
All right. Well, with that, I will wrap it up, and I want to say so much and happy Heart Month. It's almost over. But keep wearing red in recognition of women's health, and keep those healthy arteries and veins and hearts going. So I appreciate all the hard work everybody does out there, especially you, Christy, and the time you took to be with us tonight. So have another wonderful month, and hopefully we'll see you again next month. Bye.
Thank you.